All right, so we're going to get started. I just want to introduce myself a little bit. My name is Dr. Ari Isaacson, and a little bit about myself. I went to medical school at the University of Rochester in upstate New York. I then I went to undergrad there. I went to medical school at USC in Southern California. After USC, I was in the Navy for several years, and then I came to residency at UNC in North Carolina in Chapel Hill, and I was stayed there for my fellowship. And then when I was done there, I was on faculty there for 8 years. At that point, I got involved in research, and I started researching prostatic artery embolization, or PAE, very early on, and went on to do several studies involving PAE. And so it was an early focus of mine. So I've been doing PAE now for about 10 years, and as of this point, I've done it about 4,000 times. In 2021, I left UNC and I joined IR centers where I work currently in Briar Creek, and that brings you up to date with where I am. So that's my background, and here's what we are going to do tonight on the webinar. I'm going to talk a little bit about BPH, or benign prostatic hyperplasia, and what that is. We'll also talk about different procedures that are used to treat BPH, including PAE, the prostatic artery embolization. We'll then focus more on PAE and talk about how that's performed. And then we'll talk a little bit, about the expected outcomes for the procedure. And then I have a short video to kind of show you what it's like to have a PAE at our location. Throughout the presentation, you're welcome to ask questions. And the way that we're going to do that is I'm going to ask you to type your questions into the chat. When we're done with these items on the agenda, I will then stop sharing my screen and go and open the chat and start answering those questions. So feel free to put in a question at any time. And at the end of the presentation, I'll go back and answer those questions. Okay, so let's start with talking about a little bit about what BPH is. So, well, I guess first I'll tell you a little bit about interventional radiology. So I'm an interventional radiologist, and I work closely with urologists as part of the Associated Urologists of North Carolina. And what I do is I do minimally invasive procedures that involve imaging. That's why it's considered part of radiology, because there's some imaging involved, whether it's X-ray or ultrasound or CT scan. But I mainly do procedures that take the place of bigger surgical procedures. And so we do that by putting catheters into arteries or veins, or puncturing through skin to put tubes in kidneys or bladders and things like that. And that's what an interventional radiologist is. Now, where I work, IR centers is considered an outpatient-based lab, or an office-based lab that provides IR procedures, and it does it in a way that I hope is very patient-friendly, allows for easier access. You get in and out much quicker, more personalized care from each of our staff, and hopefully the whole experience is just a better experience than going to a big institution where you're one of 40 patients instead of one of 3. All right, now a little bit about BPH. So what is benign prostatic hyperplasia? So it's a natural process that tends to occur in aging men, in which the prostate grows larger. You can see from this diagram right here that the bladder sits right above the prostate, and then the tube that carries the urine from the bladder down to the end of the penis, called the urethra, travels right through the prostate. So when this prostate grows, it can push on the urethra and cause it to be difficult to urinate. Now, there's 2 types of symptoms that people get from BPH. There are the irritative symptoms and the obstructive symptoms. Sorry, it keeps advancing like that. The irritative symptoms come from the prostate pushing on the bladder itself. And those symptoms include very frequent urges to urinate, having to get up at night to pee, the feeling like you have to urinate very urgently when the urge comes on. All those things are irritative. The obstructive symptoms are more of what's happening because the prostate is squeezing on the urethra, and that's a weak stream, inability to empty the bladder completely, straining to get started. So those are all of those symptoms are different parts of BPH. So how many people get BPH? A lot, right? We say 50% of men over the age of 50 and 80% of men over the age of 80. So if you live long enough in your life, you will develop some degree of BPH. And then there's another statistic that's really important, that a lot of men avoid treatment for BPH because of the side effects, whether it's medication or procedures. There are a lot of side effects, and because of that, a lot of men just live with their symptoms, which is unfortunate, and that's one reason why PAE is a good option. All right, so let's talk a little bit about some of the other procedures that are available. So this is a little bit of a display of other things. So we're going to talk about Urolift here, which is demonstrated here. PAE is what I do, Rezūm, and aquablation, and we have videos that go through each of these so you can kind of see what they are. So the video is in the top left corner here. This is a Urolift. And basically what's happening here is there's an instrument that's inserted through the penis, and it's compressing the lateral lobe of the prostate. And then it's inserting a suture around that lobe and causing it to stay compressed. And what that's doing is basically creating more room for the urethra and for the urine to come through. Now, in the top right corner, you're going to see a video about Rezūm. This is, again, an instrument goes through the penis. It gets inserted. A little nozzle comes out that then ejects hot water vapor. And that hot water vapor causes the death of cells in the prostate. And the prostate becomes shriveled to some degree, and that's what allows the urethra to be opened up. All right. And then in the bottom left, probably the most difficult to watch perhaps of these videos, is the aquablation. The patient is under general anesthesia, so they're not aware of what's happening. There's a probe placed into the rectum, to ultrasound probe to view the prostate, and then an instrument placed through the penis that has a very high-powered water jet, and that causes the destruction of the prostate. As we saw here, you can see it one more time. And that's all automated, so it's robotic. And it can be done very quickly. So these are all procedures that can be done for BPH. And the way we determine what's most appropriate is usually based on size. Bigger prostates have less options. So Urolift and Rezūm are meant for smaller prostates, while aquablation can be done on larger ones. And so that's one of the main determinants. The other main determinant is how much risk someone wants to assume, whether they, how important it is to preserve sexual function, how much pain, are they on blood thinners? Those are all things we consider when picking a treatment option. All right, so let's focus on PAE now, or prostatic artery embolization. This is what I do and have been researching and doing for 10 years now. So the main point of this procedure is to block the blood flow to the prostate. And we do that by putting a very small catheter about the width of a piece of spaghetti into the artery, and we advance it through the arteries until we get to the branch that supplies blood to the prostate. Once it's in that branch, we inject microscopic particles that are intended to block off the artery, and then because the prostate is starved of blood and oxygen, it shrinks and causes the urethra to widen. Now here's a video demonstrating prostatic artery embolization. You can see how this catheter is being guided through the arteries. There's the bladder, there's the prostate, and the particles are being injected just into the prostate. And then because the prostate is being starved of oxygen, it will then shrink and allow the urine to come through more easily. The advantage is that it doesn't go through the penis and just does a very small puncture into the femoral artery. If you look over here on the right, you can see this is a canine prostate actually that has BPH, and then this is a canine prostate about 6 months after embolization. All right, so this is actually what we see when we're doing the procedure. You're seeing these are X-ray images. So in the top left is a video of what the interventional radiologist is doing, and then in the main screen in the middle is what we're looking at. And when you have a PAE at our location in Raleigh and IR centers, you get your own screen if you choose to watch this as well. So basically, the interventional radiologist has injected contrast dye to create an angiogram to show where the prostate is, and then has threaded this microcatheter to the right position, where now he's injecting beads that are mixed with contrast into the prostate, and the prostate then gets more it gets darker on the screen as the beads come in. I'm going to play that one more time so we can see it one more time. So first an angiogram to show all the branches of the pelvis, and then a microcatheter. A microcatheter gets inserted through the base catheter there. So you're going to see another catheter get inserted, and it'll look like a little piece of spaghetti that's coming in. So here comes the microcatheter. And we use a map, or a road map we call it, which basically takes the angiogram and turns it into inverted, so it's now white. And now you can see the microcatheter coming in, being positioned in the right spot. And there's the prostate right there, the big smudge in the middle. And at this point, the beads are being injected. They're mixed with contrast, so you can see them on the screen. Looks like little pulsations of contrast coming in there, and the prostate in the middle gets darker and darker. And we do that until no more beads can fit. So whatever the capacity is the prostate has for beads, we fill it up, and that's the end. This is the same thing again, so we'll move on. All right, so in post-op recovery, in our center, after we complete the procedure, we place what's called a closure device in the right femoral artery where we punctured. And that device is dissolvable, so there's no sutures required or anything to take out. It just dissolves on its own, and it's basically a patch on top of the artery. And in order for that patch to seal correctly, we need patients to lie flat for about 90 minutes afterwards. A lot of times patients ask, can they drive themselves to the procedure? At our location, patients can drive themselves if they choose to not have Valium. We offer every patient to have Valium before. It's just a relaxant. And if they choose not to have that, then they can drive. Now, we don't put patients to sleep for this. I didn't mention that earlier. Patients are awake because it's not a painful procedure, believe it or not. We give a local anesthetic before we puncture into the artery, and once the catheter's in the artery, there's no nerves inside the artery, so you don't feel the catheter moving around. So it's not a painful procedure. So patients are awake during the procedure, and some, actually most, choose to have Valium before as just a way to relax themselves, but some choose not to. And if you choose not to, you can drive yourself. All right, what about recovery after PAE? So here's what we tend to see. For the first 5 to 7 days, there's something called the PAE syndrome, which includes symptoms that are very similar to a urinary tract infection. So you can see them listed there. The frequency, you're going to urinate very often, nocturia, which means getting up at night to urinate, dysuria, which is burning with urination, and weak stream. So those things tend to happen in the first 5 to 7 days, and we do provide medication to help alleviate those symptoms. But you should anticipate that your urination is going to get worse initially for the first week, and then after that, it'll start to get better. You can see on this graph, IPSS stands for International Prostate Symptom Score. So that's basically the higher the score, the worse the symptoms are. And so as the time goes on, you can see most of the symptoms resolve or get better within the first kind of 6 weeks, I would say. And then it continues to get a little bit better out to 3 months. And so just to summarize this, after the procedure, the first 5 to 7 days are worse, and then it gets better. Usually at about the 2-week mark, patients start to say they notice an improvement from baseline, but the full kind of effect takes about 3 months. All right, so some common patient questions. I'm going to go through these, and then we'll watch that video, and then I'm going to address the questions that are in the chat. All right, so is the procedure painful? It is not painful, like I said. We do give a local anesthetic, which stings for a second, but then once the catheter is in the arteries, there's really the only sensations you feel are kind of a warm sensation when the contrast is injected, but otherwise it's not painful. All right, what are the risks? The risks are mild. It's a minimally invasive, so they are mild. They include blood in the urine, or blood in the stool, or blood in the semen. If any of those three were to happen, it would resolve on its own within a few weeks. You can also, it's possible to get a hematoma, which is a collection of blood under the skin where we puncture. That would be like having a rubber ball in the area where we puncture the artery. If that were to happen, it's not an emergency, but we would want to take care of it for you. As far as sexual function goes, the chance of having a change in sexual function with this procedure is very low. And that's what differentiates it from other procedures that deal with BPH. Do you have to go through the penis? No. Will I be able to stop my prostate medications? Most patients do. I would say about 2/3 of patients do, but we don't stop them immediately. You have to continue them for probably about 6 weeks afterwards while the prostate shrinks, and then you can try stopping them. Is PAE covered by insurance? Yes, it's covered by most insurances at this point. What should I do to prepare for the procedure? One of the great things is you really don't have to do much of anything. You don't have to fast. You don't have to stop any of your medications. You can just basically come that morning and we'll take care of it for you. How long will it take before I notice improvement in symptoms? So usually we see this in the 2 to 3 week range, that patients start to see some improvement from their baseline. And how long will that improvement last? That's a good question. So this procedure does not last forever. It tends to last on average around 5 years. Now, the range is probably 2 to 10 years, but the average response is about 5 years. So why does it not last forever? Well, what the body does is it grows new arteries that bypass the detours or bypass the blockages and create detours. So over time, new arteries will grow, create detours around the blockages, and the prostate will start to grow again, and that's why symptoms will return. Can the procedure be repeated? Yes, it can, multiple times. When can I resume normal activities? So we're going to tell you not to lift anything heavier than 15 pounds for 3 weeks. I'm sorry, 3 days, for 3 days. And after 3 days, you can go back to most activities. Now, if you do anything that's really strenuous, lifting heavy weights at the gym, work where you're really lifting big loads, we're going to tell you to wait a week on that. And also for sexual activity, we're going to tell you to wait a week. But most activities you can resume in 3 days, and there's really no time in bed. You're not down at all. You can walk and drive the day after the procedure, but we're just not going to want you to lift anything heavier than 15 pounds for 3 days. Okay, so at this point, I want to show this video that we have about the experience of having this procedure. Let me make sure you all can see that. Okay, sorry, let me get you shared here. Okay, share this. I'll go full screen. Hi, my name is Dr. Ari Isaacson, and I work at IR Centers Raleigh, and I perform Prostatic Artery Embolization, or PAE. This video is meant to help you understand what it's like to get a PAE at our office. So please take a few minutes to watch the video, and I hope that it answers all of your questions.
So I'm actually going to send it to your email if that's okay.
I went to medical school at the University of Southern California. After I graduated, I served in the Navy for a few years, and then I ended up at radiology residency at the University of North Carolina. I stayed there for my Interventional Radiology fellowship, and when I completed that year, I was hired as an attending radiologist at the University of North Carolina. I practiced interventional radiology there for 8 years before I decided to come here and open up this practice, IR Centers Raleigh. The reason I made the decision to come here is because I wanted to have the opportunity to have a practice that really focused on patients, where patients could have convenient parking, walk in the door and feel like they're getting personal attention, see the doctor before and after the procedure and as much as they wished, and be able to contact the physician also, if they wanted to call and ask a question, that they would get a call back from the doctor, which is, I hear, relatively rare these days. This practice allowed me to do that, as well as perform procedures that I really enjoy, which are embolization procedures, and specifically PAE, or Prostatic Artery Embolization. Hey there. Hey, how you doing?
Hey,
I'm Dr. Isaacson. How are you?
All right.
Okay. Do you have any questions for me about what we're doing today?
What we do is, during your prep, what you can expect is that we'll bring you back. We start an IV, get you in your birthday suit, get you in a gown, get you some fun little grippy socks and some warm blankets, give you a couple pre-op medications, and give you Valium. If you're feeling nervous, that is optional. Dr. Isaacson will speak with you as well, answer any questions. If I didn't answer anything for you, he can do that. So he meets with you pretty quickly.
Okay, hello. Hello. How are you doing? Hi, I'm Dr. Isaacson. So our plan for today is
When patients arrive in our office, majority of our patients are nervous and anxious, and they don't really know what to expect coming in. We really like to inform our patients that there's no pain to be expected with this procedure, but they do also get to speak with the doctor before the procedure, and that tends to help calm their nerves, because he will then answer any questions that they have, and we can also go over the procedure again and recovery process.
So tell us why you like to go in and talk to the patient.
Yeah, so I think every patient wants to see their doctor before the procedure. It gives them an opportunity to ask any questions. It's also part of the consent process, so part of them giving consent to do the procedure is that they've had all their questions answered. So it's important that I give them the opportunity to ask any questions they have before they go in. And then what I really want to, the message I want to get across in the morning is just a message of encouragement that this is going to go well, and you're in good hands, and it's not going to be painful, and it's a good first step to changing the rest of your life.
We take you back during the procedure. We'll get you hooked up, get some vitals. That'll be monitored every 5 minutes. It's a little chilly back there, so we make sure we get you covered up with some blankets. One of the guys will usually shave your groin. They like to crack the joke that they're barbers. They're usually pretty funny, and they'll help keep your mind at ease as well.
How you doing, gentlemen? You doing all right? Yeah. Good, yeah.
A lot of the emotions that the patients are having, it's on a very large spectrum. We have some that are calm, some that are nervous, and of course the nervousness comes from the unknown. So I just really try to bring them in and let them know that, we're all on the same page, and once they're in our hands, they're safe, they're good.
Coming to IR centers, you are going to definitely see that we do this all day, every day. So with us doing 4 to 6 cases a day, our cases tend to be 30 to 45 minutes long, so that's made us very efficient at what we do. Here, this is what we specialize in.
I have 2 friends that underwent the procedure, and they both spoke very highly of the procedure, and so from that standpoint, I really questioned them a lot. Like, were there any side effects? Did you, how was your sexual function afterwards? And I asked them a lot of questions that made me feel very comfortable.
I got in, they prepped me, gave me some Valium, I believe. I was like, okay, I'm not as antsy right now, but they did the IV. Doctor came in, we talked a little bit. He kind of went over what was about to happen. We went into the procedure room. He said, this is what's going to happen. This is how it's going to go. We're going to show you actually what we're doing on the screen while we're doing it. We're going to talk you through it so that you'll be at your highest comfort level.
What number of procedures is this?
This is somewhere between 3,500 and 4,000, somewhere in there, over 10 years. All right, well, we're on our 4th case of the day, so working on our efficiency, trying to do every case as perfectly as possible, but getting these patients out as quickly as possible. so they can get back to their lives and they don't have to be spending their whole day in our building.
During your procedure, you'll always have a nurse in the back with you, and so we'll help keep you comfortable back there. And we also like you to be as involved as possible and be able to watch if you want. So the first thing he'll do is numb you up there in your groin, and once he's done with that, we take it away and we can pull up a TV screen where you can actually watch and see what he sees. Either I or one of the other nurses will explain what you're looking at and kind of walk you through it. I've been compared to, let's see, Vanna White, a Universal Studios tour guide. So I really walk you through it and make it really easy for you to understand. Where each study needs it to first, and then the catheter slips down over into the vessel, okay? And so the wire acts as a guide. He'll usually go in through the right and go up and over to the left side first. So I explain that, I point out where the catheter is and the wire that he uses to guide the catheter. I show all of that to you and make it really easy to understand. So patients tend to really like that. It helps kind of distract you and you're not just staring up at the ceiling. And yeah, so it's really fun. You get to watch the procedure and we'll just monitor your vitals throughout. But again, no pain, so you're pretty nice and relaxed. You get to listen to music with us, and we'll crack a few jokes if you're lucky to. After the procedure, once he's done, he just removes his catheters and he'll get you closed up with a little closure device. No stitches involved, and then we'll take you back up front. And usually the hardest part for patients is going to be laying flat for 90 minutes. And so if that's the hardest part, then I think that's pretty easy.
Then I went back to the recovery room for a period of time, maybe 90 minutes. And then my wife came in, we sat there for a while, and then they took the IV out and I left. So it was pretty good.
Hey, so I'm going to start going over some of the discharge information with you before we get you up. After they come back from the procedure, we like to check in on them around every 15 minutes just to check the incision site, also check some vitals, just to make sure they are stable. We also will go over discharge instructions with the patients before they leave. They will have a packet of information that they will go home with. When I do my 1-month follow-up phone calls, I like to check in on the patient to see how they're doing. I always like to check to see how the recovery process was. I always do like to inform them they can still continue to see improvement for the next 2 months because they should see the full effects of this procedure around 3 months.
And most people possibly not go through the procedure because just fear. Coming from that angle, I definitely want people to understand this procedure has been beneficial for me.
Compared to the other procedures that you can have, it is one that comes with the least amount of side effects, the least amount of pain, and it does not prevent you from having anything else done in the future.
I would definitely recommend having it done.
My advice that I would give is definitely call us. You're more than welcome to come into our office.
And I was telling my spouse that, hey, I think this thing is working. She was happy because, you know, when you're going through something like this, then it's affecting everybody around you.
It's a very personal decision, and everyone should be informed and see doctors that do each of the procedures that they're considering. But PAE does offer the advantage of minimal pain, minimal risk, and a quick recovery. Thanks for watching the video. I hope this has been helpful. If you have any other questions that haven't been answered, feel free to reach out to us. And we'd love the opportunity to see you as a patient. Okay, so at this point, I'm going to go ahead and go through the chat and see answer some questions. All right, well, the first question is, will the presentation slides be made available? The answer is the slides are not, but a recording of this will be available. So if you're interested in a recording of this, there's going to be an email that will follow after this presentation, and you can respond to that email and ask for the recording of the presentation. All right, and then is PAE in the hospital? No, it is in an outpatient office that we just showed. Are others able to hear? There's no sound. I hope others have been able to hear. Otherwise, no one's heard anything that I said the whole time, and that would be disappointing. So hopefully you were able to hear. Does PSA numbers go up with PBA? PAE is what you mean. Actually, PSA goes down. So what we see after, well, let me take that back. It will go up in the immediate time afterwards. So if you check your PSA, let's say your PSA is 4, and you check your PSA, I don't know, 3 weeks after the procedure, it's going to be higher than 4. It's, you know, how much, not, I don't know exactly, but it does go up. When we destroy prostate, destroy the prostate cells, it releases the PSA into the blood, and that causes the number to go up. So it will go up initially, but over time, it'll actually go down. So if you check it 6 months after the procedure, it should be about 60% of what it was before. So you're looking at, you know, maybe it's like 2.8 or so if you started at 4. All right. Is PAE effective for diagnosis of bladder neck obstruction? Had Urolift procedure, but it had no beneficial effect. I think you mean, is it effective for treatment of bladder neck obstruction? It is effective for treatment of bladder neck obstruction if that is due to the prostate. If you have a bladder neck stricture, then it is not going to be helpful for that. Then you'll need a different procedure for that. So if you know that your obstruction is due to the bladder neck itself, then that your PAE would not be helpful for that. All right, had a PAE in February, good for a couple of years, but sorry, it's hard to control this. Good for a couple of years, but not back to pre-PAE, but now probably now back to pre-PAE issues, I think, is what it says. Let's see, getting up, Flomax here. So I would say that happens. For some people, you know, like I said, the range is 2 to 10 years. So if you're back a couple of years, my recommendation, if you're up for it, is to maybe have another one. We see good results in a second try, especially if people responded well the first time. So I would recommend considering coming back for another PAE at this point, unless there's one of the other procedures that you would rather do, and then by all means. But we can repeat the procedure, and it is effective usually when people have had a response initially, like Mr. Don Rogers, like you have. Okay. Does BPH affect sexual function and/or influence ED in any way? And if so, does PAE provide any relief? It does not improve ED, right? So PAE is not going to improve ED. In very rare circumstances, so I've done, like I said, around 4,000 cases, in a handful, people have reported worsened erectile function, and some people report reduced ejaculate. It's very rare, though. It's very rare. All right. I understand this procedure has a steep learning curve. What are the challenges in the procedure, pitfall in less experienced hands, and what are complication rates in your hands and nationally? All right, so it is, yeah, it's a difficult procedure. Within interventional radiology, it's thought to be one of the more difficult procedures. The challenges are twofold, or threefold, actually. First is identifying the prostatic artery, and that's difficult because every patient is different. The anatomy is not the same in every patient. It's different in every patient. And so you have to know, you have to have different tools. You have to be able to identify patterns, and doing this a lot of times is very helpful. So at this point, that's something that I'm very good at, is identifying where the prostatic artery is. The second difficulty is actually getting the catheter into that artery. Sometimes the angles that have to be traversed with the wire and the catheter can be very difficult. And so those are the two main challenges. The last challenge is making sure that all the particles stay in the prostate, and go in the prostate and stay in the prostate. So those three things can make this procedure challenging. And what are the complication rates? So the chance of having a major complication is defined as something that results in hospitalization, surgery, or prolonged medication, is less than 0.5%. And so, and that's what's reported in the literature. As far as our complications, I would say ours are a little bit lower than that. And as far as minor complications, we probably have about the same nationally, or if not a little bit more, and I'll explain why. We're talking about very minor things here, like blood in the urine or blood in the stool. I use smaller particles than most people use for my procedures, and the reason I use smaller particles is because I believe it will result in a more, will have a higher rate of efficacy and a more durable result, meaning that the result will last longer. The downside of smaller particles is they cause more minor complications in the first week or 2 weeks. But I think, given my experience, I think that the higher efficacy and the longer duration of the result is worth that. So I think for the minor stuff, we're probably the same as nationally, but major we have less complications. How long can you plan for results? So we talked about that. The range is 2 to 10 years, but the mean is probably 5 years. So on average, about 5 years would be the answer. With age, many men get some type of prostate cancer. Can you still have the procedure if the cancer is slow growing? Yes, you can. Yep. In fact, what we know from some research is that PAE, when you have the procedure and you have cancer, it actually reduces the number of cancer cells in your prostate. It's not a cure by any means, so it's not used to treat prostate cancer, but it does reduce the cancer in the prostate. Would a prospective patient who has been determined by cystoscopy to have an enlarged median lobe causing recurrent urine retention be considered for PAE? Yes. Our research shows that having a median lobe does not change the outcomes of PAE unless the prostate is considered on the very small end, which would be in the 30 to 40 gram range. So if the prostate's bigger overall, above 40-ish, then having a median lobe doesn't affect outcomes. But if the prostate is small, in the 30 to 40 range, then there are less positive outcomes. All right, I'm entered a clinical trial at UNC to have a spreader inserted. How does that compare to the ones you're talking about? I have to say I don't think I'm up on the spreader. I think it's probably a stent type of procedure like iTind, which gets placed in the urethra and then removed later on. But I would tell you I don't do that procedure, and so I don't have the data on that, and I'm not sure how it does compared to PAE. So I would refer that question to your urologist at AUNC. All right, cutting off blood flow concerns me. Any chance of ED symptoms resulting from the procedure? So like we talked about earlier, it has happened in a handful. When I say 5 to 10 patients out of 4,000, so it can happen, but it is very rare. Are repeated procedures after 5+ years covered by insurance? Yes, they are covered by insurance. Even it doesn't have to be 5 years. You could come back 3 months later and it'll be covered by insurance. What is the success rate? And if it doesn't have the desired outcome, would it potentially work better after a second or third time? Yeah, the success rate for most patients is 80 to 85%. If your prostate's on the bigger side, that would be over 80 grams or so, then it's even higher success rate. It's closer to 90%. And if you don't get the desired outcome initially, I would say if you had some kind of response, like the patient question earlier where he said, I initially had a good response, but it wore off after a little bit. If that's the pattern, then yes, it is good to have it a second or third time. I would say if you had a PAE and you had no improvement after the PAE, then it's probably not going to be helpful to have a second procedure. I'd like to have a PAE. What's my next step? Great. All you have to do is give us a call. I'm going to put up our phone number and email at the end and our contact info, and you just have to call the office, and we'll set up a consultation, and I'll give you it'll be a phone consultation, or you can come in person if you'd like, either way. And we'll talk about it. You'll talk about your specific case and set up the procedure if it's appropriate. All right. Wow, I'm not good at controlling these things. All right. Let's see. Back to where I was. It sounds like you are only embolizing one side. Is that correct? No, that is not correct. We are embolizing both sides. That's our goal in every procedure, and we achieve that in about 98% of our patients. Let's see here. What was the end of that question? Is that correct? If you need a repeat, do you just do this side? No, we do both sides every time. Every time we go in, goal is to embolize both sides. Okay, hi, Dr. Isaacson. I'm a patient of yours, and my experience with PAE several years ago was just as you described. Things have been great for these last several years, so I'm very grateful. My PSA has been at 2 since then, and a few prostate issues. What symptoms can I expect to experience as my prostate figures a workaround? Yeah, so it's probably going to be similar to how it was before you had the procedure. So those symptoms will creep back, whatever you had previously. If you had frequency, if you had nocturia nighttime, whatever you had previously will probably start to happen again. How long does the procedure take typically? Usually 30 to 40 minutes is pretty typical. After 5 years, as symptoms disappear, are symptoms similar? Yes, they're similar to pre-surgical values. They tend not to be worse. They tend to just be back to what they were before the first PAE. What's the risk of going to urinary retention? Yeah, that's a good question. So it happens every so often. I would say it's about 5%. It's about 1 in 20, maybe a little less than that, 1 in 25. It's usually people who've needed catheters before, so we have some kind of clue that it might be a risk. But it's between 1 in 20, 1 in 25 patients that go into retention and need to be catheterized. How long after having this procedure can you have another surgical procedure like back surgery? I think probably, as long as your surgeon's okay with the medications you're taking, you could probably do it 2 days later. We do prescribe antibiotic and some steroids, so that's something to take into account. So I think probably a week later would be fine. You'll be done with all of our medications. So you can have a PAE and then a week later have a back surgery. Is there a higher risk of cancer? No, there's no, we don't know that there's a higher risk of cancer after a PAE. And there's no evidence to suggest that or some kind of physiologic, I don't know, there's no reason to think that. Okay. Can this procedure be done if I'm taking a GLP-1? Yes, absolutely. Yeah, GLP-1, there's no problem with that. Is a catheter used so we can easily stay flat for the requisite? Good question. No, we don't routinely put catheters in, but obviously it's hard to lie flat for 90 minutes without urinating. So here's what we'll do. If you need to urinate afterwards, which most people do, we're going to give you a urinal to try to use while you're lying down. Most people can get some urine out after the procedure while lying down. If you cannot, we will get you up to use the bathroom. So we're not going to leave you uncomfortable, we promise. Most guys who come through and have this have to urinate at some point during the procedure or after the procedure, and we're used to that. We'll take good care of you. I've already had a PAE, but it's starting to wear off, are coming back significantly. How severe must my symptoms be before a second PAE? They don't have to be very severe. As soon as you feel like it's starting to come back, I would talk to us again about a second PAE. And it is covered by insurance. There's no issue with that. I have stage 4 prostate cancer. I take Orgovyx and Arietta. Should this be okay for me? Yes, it's no problem. If you're having urinary symptoms from your enlarged prostate, even with stage 4 prostate cancer, that's not a problem. We can still do a PAE for you. What functions does the prostate perform? It creates a seminal fluid. True. Will that be curtailed? Any other functions? It does create fluid. That's right. And you may notice a reduced amount of ejaculate. Some patients do report that. Other than that, the prostate has very little function other than to be a nuisance. What is the typical time frame to have to repeat the process? So usually 5 years, around 5 years. So so again, 2 to 10 years is kind of the range, and then 5 years is the average. Do you have to have a Foley catheter after the procedure? No, most patients do not. On average, how long does the PAE last? About 30 to 40 minutes. How do you work with my urologist to determine whether I'm a patient who's a candidate for this procedure? Yeah, so the vast majority of our patients see urologists initially. They work up the patient, do the tests that tell them that it's BPH is the problem. Usually they get a size of the prostate or a PSA number to kind of give us a hint. And then they'll offer options of different procedures to the patient. And at that point, if the PAE is something that the patient wants to do, they'll refer the patient to me to talk about PAE. So that's kind of how the collaboration works. Is this procedure recommended for prostate level 1 or 2? I'm not sure I know what prostate level 1 or 2 is referring to. So it's hard for me to answer that. It's basically recommended for anybody who has enlarged prostate and urinary symptoms due to that enlargement. Having the prostate be more enlarged tends to be more helpful for the procedure and leads to better outcomes. Does this procedure increase the risk of prostate cancer? No. Why don't you AUNC docs do this procedure? Because they're urologists, and urologists don't do this. It's an interventional radiology procedure. That's why I do it. How can we best present this procedure to our insurance carrier? We take care of that for you, so you don't really have to worry about that for the most part. We're very experienced at getting it pre-authorized, so we'll do that. If we do have any issues, we'll talk to you about it and what the next steps are. But at this point, most insurance companies are covering the procedure. Is this procedure effective for overactive bladder? No, it's not. If that's the main issue, then this is not going to be helpful, nor is really any other BPH procedures. The main thing for overactive bladder are going to be medications like Gemtesa or oxybutynin. Those type of medications are going to be the best for that. All right. How many of your patients out of 4,000 suffered sexual? Yeah, like I said, I think as far as I know, it's somewhere around, I would say 10 to 20 that I know of. What is the hole-up procedure and how it's compared? Yeah, so a hole-up is holmium laser enucleation of the prostate. It's a procedure done in the hospital under general anesthesia. A laser is inserted through the penis, and the laser is used to kind of scoop out to break up the material of the prostate and then remove it. So it takes out more, it removes a bunch of the prostate. It can be used on larger prostates, so that's helpful. And it lasts longer than PAE because you're removing the tissue. The downside is it can cause ejaculatory dysfunction, bleeding, and it requires hospital stay and going under general anesthesia. So there's pluses and minuses. And it's more painful than a PAE. What is the success rate? What types of problems have you encountered? Success rate tends to be 80–85%. Again, if the prostate's bigger, it's a little better than that. The problems we've encountered, sometimes people have anatomy that that make the procedure very difficult. And so that can be a problem at times. If there's calcification of the arteries or blockages, that can be hard. As far as other problems, we have had a handful of issues of different odd things that have happened to individual patients, but I don't really think they don't generalize to the population. So it's mainly the things I talked about earlier. The complications can be, we talked about a very small amount of patients requiring a catheter afterwards, but blood in the urine, blood in the stool, blood in the semen. Having a small amount of patients having a reduction in the erectile function, like I said, very rare, and a small amount of patients reporting a reduced amount of ejaculate. All right, I've had a biopsy which indicated, sorry, let's see here. I think, what are the long-term effects of plastic pellets in the body? We've used the same plastic pellets for 20 years. They've been engineered to be inert, so we haven't seen any side effects of them in the body, nor they've been, they test the blood to see if anything's being leached out into the blood, and there's nothing there. So as far as we know, there are no long-term effects of the plastic pellets in the body. In the case of prostate cancer, is the procedure possible helpful? It is possible or helpful to treat symptoms of difficult urination, but not to treat cancer, right? So it doesn't treat the cancer, but if you have prostate cancer and you're also having difficulty urinating from your prostate, then it can be helpful. How can you confirm that a repeat procedure is indicated if no serious symptoms? Is there any limit to prostate size? So again, if you had an initial procedure and you responded in some way, you had some improved urination, then a second procedure would probably be helpful to you. Is there a size limit? There's no size limit. We can do it as big as they come. On the smaller end, again, the efficacy goes down probably less than 40 grams. But as far as upper level, you can do it as big as it comes. Sexual function, we talked about that a bunch already. Is PAE better for those with larger prostates? Yes, it tends to work better on larger prostates. If you're on Eliquis, that's fine. We can do the procedure on Eliquis. We do that for many patients, and the bleeding risk is just mildly higher, but not enough to be too concerned about it. How many days after the procedure can you travel, airline travel? We have patients who fly out the same day after they have the procedure. They'll have the procedure and then fly out that afternoon or the next day. Now, you're going to have to pee. If you leave the next day, you're going to have to urinate quite frequently, and that can be hard on traveling. But it is possible to travel same day or the next day or 3 days later. Is there a risk of pellets moving out of the prostate? No, once they're in there, they stay in there. So there is a risk of them being put in the wrong place, and that's why you come to me, and I do this with a lot of experience and make sure they go into the right place. But once they're in, they don't move around anywhere. I've had a biopsy which indicated my early stage prostate cancer, 3 plus Gleason 6. My urologist is monitoring and watchful waiting. Is that an issue? Not an issue at all. We can have a PAE. That is fine. No problem with Gleason 6 cancer. You can have a PAE. Can this procedure be performed when the patient has had brachytherapy? Yes, it can. And grade excludes. I hope to see you soon. Okay, thanks. Appreciate that. All right. Yeah, no problem with prior brachytherapy. We can do the procedure. Can you say this procedure can you have this procedure if you had Urolift? Yes, we do many patients that have had Urolift already. That's not a problem. How many days in advance do I need to suspend taking Plavix? You actually don't. We will do this procedure taking Plavix. It's not, like I said, it's minimally invasive. There is a slightly higher risk of hematoma afterwards, but it's not that big. Could you please elaborate on radiology aspects, dosage similar, something to worry about? Sure. We do use radiation from the X-ray, but it's very low. It's about, it's less than half of a CT scan. So if you think about getting a CAT scan, it's about half the radiation of that or less. So it's not something to worry about. There's no evidence that we've seen that there's any bad effects from having this procedure from the radiation. Does this procedure work with large prostate? Yes, it works very well. How many days until I can do a rigorous swim workout? For swimming, I'd probably give it 5 days for swimming, and you can go back in the pool and swim then. If you were 3.5 years out of PA and your PSA is going up, is that a sign your prostate is enlarging again and not having worse? Maybe, but if your symptoms are still okay, then I wouldn't worry about it yet. I'd probably just go by your symptoms. If the symptoms start to get worse, then come back and have a repeat PAE. How is PAE compared to other procedures, easier, better? I think on patients, it's definitely easier. As far as better goes, it depends how you define better. There are other procedures that are going to have a longer effect, that are going to be more dependably reliable. So that would be like, those other procedures we talked about, which actually remove tissue. But as far as minimal side effects and less pain and fast recovery, then PAE is easier in that sense. Do you coordinate with my existing AUNC urologist? Yes, I do. Absolutely. Approximate time to schedule the procedure. Usually after we talk consultation, it's usually 2 to 3 weeks to get the procedure scheduled. Complication rates, we kind of went over that already. I'm on a blood thinner. Are there any issues I may have? No, we will do the procedure on blood thinner. Over the past few years, my PSA has been between 10 and 10. 2 biopsies, no cancer. My urologist says my prostate is 3 times larger. Will this procedure bring down my PSA? Yes, it will. It will bring down your PSA significantly. Who are the best candidates? Well, we talked about this. Some patients with bigger prostates who are having urinary symptoms. Can a decision be made on PSA only? It can, yes, absolutely. If you're having urinary symptoms and you have a high PSA, we can do the procedure for you. How many days until I can paddle a whitewater canoe on a river? I'd probably wait a week on that, and then you could do the whitewater canoe on a river. That sounds pretty fun. Is PAE effective, useful, risky for a large prostate? It is effective, it's useful, it's not risky for a large prostate. So definitely a good way to go for a large prostate. What is actually injected? Organic microparticles or synthetic? They are synthetic. Yeah, they're polymethyl methacrylate at the core, and they have a coating that prevents any leaching or reactivity, but they are synthetic. It's good. What is injected in blood vessels? We just talked about that. I had a Urolift. Can I get a PAE? Yes. I've been on Flomax for 3 years and still struggle at night. How do I know if I'm at the point for this procedure? Well, if you're already taking medication and you're seeing symptoms, I think you are at the point for this procedure. I think that's reasonable. What happens to the dead prostate cells? Oh, good question. So the body reabsorbs them. So white cells called macrophages come and it reabsorb the dead prostate cells and replace them with scar tissue. Just like any injury in your body, if you were to scrape your arm, the same kind of thing would happen. But that's what happens. They get absorbed and you get scar tissue. How do you know if you need a PAE? Well, if you're having urinary symptoms and you have BPH, then you could have a PAE, and that would be helpful for you. Outside of are there any tests or evaluations that your team does prior to the procedure? No, most of that is done by the urologist, and all of it's done by the urologist. What we do is we have a few questions we want to ask you about your history to make sure that things are going to go well, and that's what so when we have our consultation, we'll tell you about the procedure, and then we'll also ask you those very specific questions. Success rates, we talked about that a little bit, but it's 80 to 85% is mainly if your prostate's bigger, tends to be a little bit better than that. Can a patient with a bilateral total hip replacement have a PAE? Absolutely. We do a lot of patients with bilateral total hip. Is the prostate totally reduced in size? Yes, it tends to be reduced by about 40% in volume after the procedure. Procedure you did was great for me. Had a catheter for 8 weeks and off the crib in 2 weeks. PSA dropped from 15 to like 4. Well, that's good. Went just as described, no questions, but a testimonial. Thank you. I appreciate that, Jerry. That's very kind of you to put that up there. I appreciate that testimonial. How quickly can your practice schedule a prospective patient for a PA after completion of consultation? Right now, it's about 3 weeks. It tends to range in the 2 to 3 week zone usually. What is the difference with aquablation? Aquablation destroys the tissue, so it tends to last longer. It's also done under general anesthesia. It tends to be a little bit more painful, higher rate of sexual dysfunction, but more reliable, more dependable. It has a higher success rate than 80 to 85%. So it's one of those ones where you're going to get probably a longer lasting effect and a higher efficacy rate, but you're going to have a higher risk of complication and more pain associated. All right, I have Blue Cross Blue, my urologist, that you referred me to your office. However, when I called a few weeks ago, I was informed that you do not accept my insurance. Could you please confirm whether you accept? Unfortunately, that is one that we can't take for some reason, and I don't know. I don't know exactly why. Marco, am I running out of time here? Okay, I'm going to have to jump off. All right, so I got to get off here because we have another webinar scheduled, but I apologize to those I didn't get to their questions. I'm going to put up the next, I would encourage anyone who has questions to give us a call. It's going to be, let's see here, I'm going to give it to you one more time here. All right, so this is where we are. This is our contact information. Take this down, give us a call. If I didn't answer your question, I apologize. I will call you back and answer it, or you can email us. But I thank you for joining us tonight for the webinar, and I hope it was helpful. And hopefully we'll see some of you at IR centers. All right, take care. Bye-bye.